Welcome in Pediatric Lecture Series. Myself, Dr. Sunil Natha Maske, working as a Dean and Professor in Pediatrics of Dr. Vithalrao Vikhe Patil Foundation's Medical College and Hospital, Ahmednagar in Maharashtra of India. Today, we are going to see a new topic, that is the pre-hypertension in adolescent child. This pre-hypertension is also known as high normal blood pressure or borderline hypertension. Initially, this terminology was used, but now it is replaced by high normal blood pressure. These are the certain pioneers who work in the field of hypertension. First one of them is the William Harvey, who was an English physician, and he described the circulation of blood in his book known as De Motu Cordis. Second one, pioneer in the field of hypertension, is the Stephen Hull, was again English person, and he has given the first description of the measurement of blood pressure in human being. Next one is a Thomas Young, who was a British polymath. He described hypertension in 1808. And last pioneer in the field of hypertension is the Paul Owen Corner, who was a Czech Austrian cardiac physiologist, and he made his contribution especially in the field of understanding of the hypertension, that too essential hypertension in adult. Now we will focus on the pre-hypertension in adolescent children. In 1939, one study was done in which it was observed that there is a sharp increase in mortality in individuals who have a blood pressure measurement greater than 140 by 90 millimeter of mercury, giving rise the usual clinical definition of hypertension. The investigators also observed that systolic blood pressure in the range of 120 to 140 millimeter of mercury, especially in the younger children or younger individuals, was associated with progression to definitive hypertension and cardiovascular disease in later life. And this systolic blood pressure of 120 to 140 millimeter of mercury, they first referred it as a pre-hypertension. This term, the pre-hypertension, was first introduced when the JNC-7 was launched at the American Society of Hypertension annual scientific conference in 2003. This term pre-hypertension caused tremendous discussion, amongst which were many objections for this new terminology was recorded. It was argued that this new definition of illness would impact an individual's employability, his life, as well as medical insurance coverage, and perhaps even converting what was an otherwise well person into a sick one. The objective of creating such a category in the classification was to increase the awareness of importance of identifying individuals in whom early intervention by adoption of healthy lifestyle would lower the blood pressure and thus decrease the rate of progression to hypertensive level in order to reduce the risk of cardiovascular diseases. An additional rationale for use of this new terminology, pre-hypertension, was the greater likelihood of the affected individual to follow healthcare recommendations. The evidence for creating this terminology of the pre-hypertension came from the results of two landmark trials. Out of them, first one was a meta-analysis, which included approximately 1 million individuals from 61 long-term epidemiological studies and the longitudinal data from the Framingham Heart Studies, FHS, which demonstrated that mortality from ischemic heart disease and a stroke in individuals aged 40 to 89 years increases in a long linear relationship with increase in both systolic and diastolic blood pressure for each 20 millimeter of mercury increase in systolic blood pressure or 10 millimeter increase in diastolic blood pressure over the range of 115 by 75 millimeter of mercury. There is a twofold increase in mortality associated with coronary artery disease and stroke. Arguments against using the use of this terminology was the fact there is a inhomogeneity within this category because the risk of progressive to hypertension and developing cardiovascular event is higher in patients with blood pressure in the range of 130 to 139 by 85 to 89 millimeter of mercury than those with blood pressure of 120 to 129 by 80 to 84 millimeter of mercury. Also, there were concerns that the term prehypertension would create anxiety among the general public. However, already in the 1920s and 30s, insurance company used the term prehypertension for slightly elevated blood pressure levels, which were well within the normal range, but were clearly associated with increased morbidity and mortality. These data accumulated by insurance companies were used for risk calculation in order to price insurance policies. The 2004 National High Blood Pressure Education Program Working Group on High Blood Pressure in Children and Adolescents, in parallel with recent updated recommendations for the evaluation of elevated blood pressure in adults, created this new terminology and given the name as a prehypertension, which identify the children at greatest risk for developing future hypertensive disease. This definition for prehypertension was based primarily on epidemiologic normal values and expert opinions and was designated to identify a group of children for whom targeted preventive efforts would be most beneficial. Seventh report of Joint National Committee on the Prevention, Detection, Evaluation and Treatment of High Blood Pressure, in short it is called a JNC-7 report. It has given definition for prehypertension in adults as presented in having a systolic blood pressure in the range of 120 millimeter of mercury to 139 millimeter of mercury and or a diastolic blood pressure between 80 millimeter of mercury and 89 millimeter of mercury level. In children and adolescents, prehypertension is defined by a systolic and or diastolic blood pressure in between 90th percentile to 95th percentile for age, sex, and height, according to normative tables published by Working Group report. However, during adolescency, the 19th percentile often exceeds the adult threshold of 120 by 80 millimeter of mercury. And in these cases, prehypertension should be considered as a blood pressure in between 120 by 80 millimeter of mercury, but it should be less than 95th percentile for age, sex, and height according to normative table. A definition of prehypertension based on ambulatory blood pressure monitoring has also been proposed for children. Ambulatory blood pressure monitoring captures multiple blood pressure measurements throughout a 24 hours period and thus provides a more complete assessment of an individual's blood pressure. American Heart Association proposed that children with a mean 24-hour blood pressure less than 95th percentile, but a blood pressure load, that is percentage of reading and or time with 95th percentile between 25% and 50% to be considered as a prehypertensive. This working group reports recommends instituting lifestyle changes as appropriate and continue to monitor blood pressure every 6 monthly in order to stop the progression to sustained hypertension. The fourth report described prehypertension as an indication for lifestyle modification and recommended blood pressure monitoring approximately every 6 months in children. No recommendation was made on repeated measurement of blood pressure to verify the designation of prehypertension. The objectives of creating such a category in the classification was to increase awareness of importance of identifying individuals in whom early intervention by adoption of healthy lifestyle would lower the blood pressure and thus decrease the rate of progression to hypertensive levels in order to reduce the risk of cardiovascular diseases. An additional rationale for use of this terminology was the greater likelihood of the affected individual to follow healthcare recommendations. Prehypertension is very commonly prevalent in the general population. The third National Health and Nutrition Examination Survey, which was done in year of 1999 to year 2000, reported that the overall prevalence of prehypertension in the United States was 31%, which was higher in men than women and was higher in obese than normal weight person. Similar data have been reported from our country, India. A recent study from affluent urban population in North India found the prevalence of prehypertension as a 31% in adult population. The National High Blood Pressure Education Program Working Group on High Blood Pressure in Children and Adolescents now define prehypertension as opposed to the high normal classification that was used previously. European Society of Hypertension and European Society of Cardiology maintains the previous definition of optimal, normal, and high normal blood pressure. The rate of progression of prehypertension to hypertension can be relatively rapid, and particularly in those whose blood pressure lie in the upper portion of the prehypertension range. Prehypertension in children, as in adults, is commonly associated with obesity, metabolic syndrome, and dyslipidemia. The risk ratio for chronic kidney disease and cardiac event are also greater in prehypertensive than hypertensive person. Now, we'll see the prevalence of prehypertension in children and adolescents in various studies. The most common and important study done by the working group has revealed prevalence of prehypertension in children and adolescents of 12% to 17% range. These are the various studies done in the various parts of the India. These have shown these various percentage. In the first one, Amrit et al. Done in the Maharashtra showed prehypertension prevalence as a 35%. Other study in the Bihar shows that near about 28% of the prevalence. Now you will see from the Gujarat, Yavatmal, Delhi, Karnataka, the near about prevalence of this prehypertension in children ranges from 3% to 30%. That means there is a gross variability in various studies. These are the national figures. Also, you can see the international figures of prevalence of prehypertension in various countries like Saudi Arabia, it is 9%. South Africa, it is 12%. In America, it is 31%. In Brazil, it is 8.6%. Then in the Iran, it is 3.25%. This is again the variable range starting from 3 to 30% of the prevalence of prehypertension in adolescent and children. Now, after prevalence, we'll see the exact definition of prehypertension. The fourth report of the task force on blood pressure control in children, commissioned by National Heart, Lung and Blood Institute, that is NHLBI, when a child's average blood pressure exceeds the 90th percentile, but it is less than 95th percentile for age, sex, and height, is known as prehypertension. In other way, prehypertension is defined as systolic blood pressure more than 120 but less than 139 millimeter of mercury, and or diastolic blood pressure more than 80 millimeter of mercury and less than 89 millimeter of mercury is designated as prehypertensive children. These are the various classification used to classify as a prehypertension. Depending on JNC7 defines the prehypertension. Just I have told, when the blood pressure, especially systolic, is in the range of 120 millimeter of mercury to the 139 millimeter of mercury, and or diastolic blood pressure in the range of 80 to 89 millimeter of mercury, whereas 2004 working group, which classifies it depending on the percentile for age, height, and gender, that is in between 90th to 95th of the percentile. Again, this prehypertension is also classified according to systolic blood pressure and diastolic blood pressure, that is in the range of 120 to 139 millimeter of mercury is the systolic blood pressure, and 80 to 89 millimeter of mercury is the diastolic blood pressure designated as a prehypertensive children. Now, after definition, we will see the risk for progression of prehypertension to hypertension. The impact of the current designation of prehypertension on the more immediate progression of blood pressure during adolescence, however, is less well understood. As per Vogelsa Heart study, which is done in children with elevated blood pressure, are 2 to 3 times more likely to develop essential hypertension as a young adult. Whereas Hockner and his colleagues initially described the rate of progression from prehypertension to hypertension of approximately 7% per year among adolescents, which included in the National Child Blood Pressure Database, for whom single serial blood pressure measurement was taken. As described by Redwin et al., overall incidence rate for progression to hypertension was 0.7% per year. The evidence reported by Redwin demonstrates that progression from prehypertension to hypertension in adolescents is not only statistically significant, but incidence rates are also clinically relevant. The impact of the current designation of prehypertension on a more immediate progression of blood pressure during adolescence is less well understood. The rate of progression of prehypertension to hypertension can be relatively rapid, particularly in those whose blood pressure lie in the upper portion of prehypertension range. There are certain risk factors for development of the prehypertension, especially in children and adolescents. Commonest is the overweight and obesity because of sedentary lifestyle, also because of stress, lack of exercise, too much intake of salt in the diet, premature birth or low birth weight babies who are also in the risk of developing prehypertension in later life. More important is the family history of hypertension and diabetes are also prone. Then maternal smoking during pregnancy, male sex are also prone, use of alcohol, tobacco, or illegal drugs by the child, disorders of sleep, especially obstructive sleep apnea, primary snoring, and sleep fragmentation are also responsible for development of prehypertension. And if the child is taking drugs like steroid or any other medication, they are also in the risk factor group. Now, clinical features of the prehypertension. This high blood pressure is often known as silent invisible killer because it usually does not cause any symptom. It does not give rise to any complaint. So most of the children with prehypertension and hypertension are asymptomatic at the time of diagnosis. Very rarely they can land up into hypertensive emergencies. Rarely, few of them may present with the headache, chest pain, loss of vision, abdominal pain, double vision, breathing difficulties, fatigue, or dizziness. Now, just I have told the symptoms and signs for this prehypertension in adolescent children are very minimum. So diagnosis of these children is very, very important. It requires skill. We have to follow the steps in the form of first take the history in detail. We have to just check the symptoms which just I have told, rare possibility of the prehypertension and hypertension. Then look his past history of the growth and developmental delay, any systematic disorders. Then see the medication history, especially of the steroids. Take the sleep history of the snoring and apnea. Then look after the family history of hypertension and diabetes mellitus. Also look the addictions which the child has, especially smoking and alcohol and illegal drugs. Then dietary history and socioeconomic history. In dietary history, use of junk foods and salted foods are very, very important, which you have to take care. Then on examination of the systemic and general, we have to see the proptosis for hyperthyroidism, arterial spasm, hemorrhages. Also look for the papilledema. If there's a moon phases, there's a possibility of Cushing's syndrome, tonsillar hypertrophy for sleep apnea. If there is a thyroid enlargement in the neck, that is hyperthyroidism. Look after the cardiac system for murmur, underlying cardiac disease like coarctation of aorta, frictional rub for collagen vascular disorders, apical hue for the left ventricular hypertrophy. Also on the per abdominal examination, look for the mass in the abdomen, that is the cystic kidney disease, pheochromocytoma, hydronephrosis. If there is a bruit, see for the renovascular disease. In pedal, you should look for the edema in the kidney diseases, joint swelling for collagen vascular diseases. Then in the skin, we have to look for the pallor or flushing for catecholamine excess, that is the pheochromocytoma, acne, hirsutism, striae for Cushing-White syndrome or steroid therapy. Capsular spots and neurofibromas are very important for neurofibromatosis. Then look for the tuberous sclerosis skin signs. Then rash for any systemic lupus erythematosus. Then see for muscular weakness, for neurological conditions. In general, see for the obesity or overweight, which is the leading cause for primary or essential hypertension, and growth retardation for chronic kidney diseases. Also look for the vital signs of the tachycardia in hyperthyroidism, catecholamine excess, blood pressure difference between the extremities. That is especially important for the diagnosis of port action of the aorta. Once you see for the history and general and systemic examination, you have to proceed in the line of investigation. There are certain investigations which are done for the first line investigations, like complete blood count with ESR, blood sugar level, lipid profile, thyroid function test, serum electrolytes. Very important is the urine analysis for microscopy, sediment, culture, urine protein to creatinine ratio. Important one is the microalbuminuria because it is one of the biomarker for hypertension. Then cardiac investigation like chest X-ray, ECG, echo, color Doppler, carotid Doppler. Then RFT for creatinine, chloride, acid base, GFR, and renal ultrasound. Also, one can proceed for carotid Doppler along with Doppler study of the renal artery. In second line investigation, you do the fundoscopy for retina, then imaging of the urinary tract like DEMSA scan or micturating systemic urethrography MCU, CT and MRI, urine catecholines, especially vinyl mandelic acid and metanephrine for pheochromocytoma or neuroblastoma. Again, these are the biomarkers, plasma renin and aldosterone level. Sometimes we have to proceed for additional investigations like polysomnography for sleep disorders, renal vein renin sampling, arteriography, isotope scan for pheochromocytoma. Also, one can do 24 hours urine for protein and creatinine clearance. Then advanced imaging like magnetic resonance angiograph, three-dimensional computerized tomography, renovascular abnormalities, especially we have to find out. Then ambulatory blood pressure monitoring for white coat hypertension. One can find out the plasma aldosterone level for hyperaldosteronism, and one should do the study of biomarkers. These biomarkers are objective, quantifiable characteristic of biological process which can be measured accurately and reproducibly. This line is very important. This should be measurable and reproducible. They may or may not necessarily correlate with patient's clinical symptoms. Common biomarkers which you see in the hypertension and prehypertension are the serotonin, nitric oxide, endothelin-1, plasma 5-HT. There are also circulating biomarkers which are indicate vascular dysfunction, prediction of hypertension, cardiac, renal, or cerebral damage. Now, very important for management of prehypertension and hypertension in adolescents. So, in prehypertension, dietary management has a very important role because this DASH diet, in short, it is called a dietary approach to stop the hypertension, which indicates low sodium and high potassium diet, use of more fruits in the diet, especially potassium-rich fruits like papaya, banana, dark leafy vegetables, sweet potato, tomato juice, oranges, milk, then fish, nuts, then pumpkin seeds, almond seeds, sunflower seeds. Along with this, non-starchy vegetables like beans, cucumbers, carrots, and use of tomatoes. It is also recommended under DASH diet, you should limit intake of trans fatty acid. One can use the whole grains. There should be low proportion of refined carbohydrates like sugar, white flour, corn syrup in diet. Child with prehypertension should drink plenty of water, and very important, avoid use of junk food in diet. These are the DASH diet servings per day, how much it is given. Fruits and vegetables should be given 4 to 5 times in a day. Low fat milk products should be given more than 2 times. Whole grains 6 times. Fish, poultry or lean red meats less than 2 times, legumes and nuts 2 to 3 times, oil and fat should be less than 1 time, added sugars and sweets, its use should be restricted. After diet, there is a very important role of lifestyle modification. The aim is reaching and maintaining the healthy weight. Then one should control the stress, regular exercise for 30 minutes, especially brisk walking. The Office of Disease Prevention and Health Promotion of America, in their recent guidelines on physical activity, recommended 60 minutes or more of moderate to vigorous physical activity on a daily basis among the adolescents. So these guidelines given by the Office of Disease Prevention and Health Promotion of America is very, very important. We suggest 60 minutes or more moderate to vigorous physical activity daily. So in short, in this hypertension lifestyle, there is very important role of the low sodium intake, weight loss, stoppage of the alcohol and addictions, important role of the exercise, avoid junk foods and eat healthy diet that is rich in fruits, vegetables, dairy and healthy saturated fats. In prehypertension in adolescents, there is a very minimal or limited role of the antihypertensive medication. But as per report published in the 4th report of the blood pressure, they have given certain guidelines about use of the medication in prehypertension and hypertension. The treatment of hypertension with drug is recommended when there is a symptomatic hypertension, that is stage 2 hypertension or stage 1 hypertension that persists despite therapy without drug. Pharmacological therapy, when indicated, should be initiated with single drug. Remaining is the treatment for hypertension, but for prehypertension, only role of diet and lifestyle modification is suggested. This is a summary chart for treatment of the prehypertension, stage 1 hypertension, and stage 2 hypertension, which we are concerned about the prehypertension, where they again recommended role of lifestyle changes, that is the overweight, screening for cardiovascular diseases, then repeat blood pressure measurement every 6 monthly. Now, how to prevent this prehypertension in adolescents? Keep normal weight as per height. Daily exercise, just we are told, for 1 hour or 60 minutes daily. Take healthy and nutritious diet. Don't take alcohol, tobacco products, or illegal drugs. Keep stress levels low. Practice relaxation and breathing exercise. Don't take extra salt in food. Avoid fast food and junk foods. Checking of blood pressure and monitoring of weight periodically. These has a very, very important role in prevention of the prehypertension in adolescents. Now, prognosis of prehypertension. The extent to which prehypertension constitutes a serious health concern remains controversial. This depends upon the underlying cause. Experience from adults shows that poorly controlled blood pressure is a risk factor for coronary heart disease and is the major risk factor for stroke. Children with raised blood pressure are more likely to become hypertensive adults. If prehypertension is poorly controlled, then its related morbidity and mortality will increase in later life, including end organ damage to kidney and heart. National Heart Lung Blood Institute suggests that people with prehypertension are at a higher risk for developing hypertension or high blood pressure compared to people with normal blood pressure. These are certain recommendations for prehypertension and hypertension in children prevention. There should be periodic screening and monitoring of blood pressure of adolescents, which should be incorporated into the school health program. Second one, general public health education on hypertension and prehypertension, along with its associated risk factors, should be strengthened. Particularly in the adolescent age group, labeling an individual having high abnormal blood pressure values potentially carries an enormous impact for the individuals as well as for the healthcare system, so that one should be careful. These trends of increasing prevalence of hypertension, prehypertension in urban as well as rural population calls for a collective effort targeted at recognizing hypertension and prehypertension in asymptomatic children. These were concerned that the term prehypertension would create anxiety among the general public. Considering the magnitude of prehypertension and hypertension, interventional strategies need to be developed for children right from their period of childhood. Then, healthcare providers should be sensitized about the situation and made capable of providing preventive measures and other service provisions. School health programs implemented through primary health centers should be alerted about the need. And last but not the least important one is the research needs to develop normative data for the children for making ideal comparisons. Now, these are the references from which I have collected the information. And this is the very important topic which I highlighted is the prehypertension in adolescents, which are directly connected with the weight of the child, that is the obesity and overweight. And this is one of the preventable and curative condition in the adolescents by just simple dietary modification and lifestyle modification, which will give rise to the healthy and better Indian youth for tomorrow. Thanks.